Welcome. Today we're focusing on something really critical in cardiology, the brand new 2025 ACC Expert Consensus Statement on evaluating and managing cardiogenic shock.
This statement is the current expert consensus, bringing together the best data we have right now in early 2025. Even with all the progress we've made in cardiac care, the short-term risk of death, we're talking 30–40%, is still incredibly high.
Yeah.
And even if patients survive that initial phase, the one-year mortality can approach or even exceed 50%. Interestingly, the picture is changing a bit. Traditionally, AMI, acute myocardial infarction, a heart attack was the main trigger.
Right.
But now we're actually seeing an increase in cases related to acute heart failure, so HF-related CS.
So it's not always a sudden heart attack causing it.
Not always. And these two groups, AMI-CS and HF-CS, they often have different underlying issues, different responses to treatment. It affects how we manage them, their likely outcomes.
Has the way we treat CS changed enough recently to really warrant this new consensus?
That's a good question. We haven't had maybe huge game-changing trial results across the board, especially beyond just getting blood flow back quickly in AMI shock.
Okay.
But there have been important developments. The danger shock trial was quite significant.
Yeah.
It was the first randomized trial showing a mortality benefit with temporary mechanical circulatory support, tMCS, specifically an early microaxial flow pump.
How exactly does the ACC define cardiogenic shock here?
The core idea is inadequate tissue perfusion. So CS is a syndrome where a cardiac issue leads to sustained evidence of clinical signs and biochemical markers that tissues aren't getting enough blood flow.
And importantly,
This can happen regardless of the actual blood pressure number.
that's a really critical point. You can have a normal BP and still be in shock.
Exactly. Normotensive shock is a real thing, and it's dangerous.
Okay, what about AMI and AMI-CS? How are they defined?
AMI, a heart attack, is basically irreversible heart muscle damage from lack of blood flow, ischemia. Diagnosis needs symptoms plus objective findings, ECG changes, cardiac biomarkers in the blood.
Standard definition.
Pretty much. And AMI-CS is just cardiogenic shock caused by that AMI, whether it's a STEMI or non-STEMI. Right. Left ventricle, right ventricle, both maybe mechanical complications like a ruptured wall. And they also include CS from acute arrhythmias or post-cardiac arrest if it's in the setting of an AMI. It's quite encompassing.
Got it. And the flip side, heart failure, HF, and HFCS.
For HF, they use the universal definition. So symptoms or signs of HF because of a structural or functional heart problem, plus either high natriuretic peptides or objective signs of congestion, like fluid in the lungs.
Okay.
HFCS then is shock directly related to that primary heart muscle problem, could be ischemic, like from old heart attacks, or non-ischemic, maybe myocarditis, other cardiomyopathies.
And there are different types of HFCS.
Yeah, they categorize it mainly as de novo, meaning a sudden, new onset of severe dysfunction leading to shock, or acute on chronic.
Acute on chronic meaning someone already had heart failure.
Exactly. Someone with chronic HF who has a sudden, severe worsening that tips them into shock. And again, it could be LV, RV, or biventricular dysfunction with various underlying causes like myocarditis, Takotsubo. Recognizing this difference matters because the cause and the patient's baseline health can really influence things.
Okay, definition's clear. Now, identifying CS early is vital, you said. The guidance introduces the suspect CS mnemonic for this.
Yes, exactly. Early recognition is probably one of the most critical factors for improving outcomes. Waiting until someone fits the old classic criteria, low BP, congestion, low output, might be too late.
Because you miss that normotensive shocks.
You miss that, and you miss the chance for earlier intervention. So you need a high index of suspicion based on the clinical picture, even before you get invasive numbers. Suspect CS is a tool to help clinicians think through the possibilities early.
Let's break it down. S is for symptom signs. What are we looking for?
Right. The first S is for symptoms and signs. This is broad. Things like altered mental status confusion, lethargy, chest pain or pressure, cold, clammy skin, a fast pulse.
Okay.
Also, a narrow pulse pressure, the gap between systolic and diastolic BP. Signs of fluid overload like elevated neck veins, JVP, crackles in the lungs, difficulty breathing lying flat, orthopnea, waking up breathless, PND, leg swelling. It's a constellation.
A lot to look for clinically. What about U?
U is for urine output, specifically low urine output oliguria or even anuria, less than 30 mils per hour or less than half a mil per kilo per hour. It's a classic sign the kidneys aren't getting enough blood flow.
Makes sense. The second S.
That S stands for sustained hypotension. So systolic BP under 90 or MAP under 65 for more than 30 minutes.
Or a big drop from their usual.
Or a big drop, yeah, more than 30 points from their baseline. Or, importantly, needing pressors or other support just to keep the systolic above 90.
Okay, so BP is still relevant, just not the whole story. Bit.
P is for perfusion markers. These are the lab tests showing organs aren't happy. Lactate over 2 millimol is a big one. Elevated liver enzymes like ALT may be over 200 or twice the upper limit. Kidney injury is shown by creatinine doubling.
Acidosis, too.
Acidosis, yeah. Blood pH below 7.2. Metabolic acidosis without another clear cause. These are objective signs of malperfusion.
Very useful objective data. What's E?
E is for ECG echocardiogram. The ECG is crucial for spotting acute ischemia, signs of a heart attack.
And the echo.
The echo, the ultrasound of the heart, looks for wall motion problems suggesting ischemia, checks the size and squeeze of the ventricles, LV and RV, and looks at the valves.
What if you can't get a full echo right away?
Point-of-care ultrasound, POCUS, by someone experienced can give you vital initial clues.
Okay. Please.
C is for congestion. Are there signs of fluid backup? This comes from the exam lung sounds, JVP, and any hemodynamic data you might have, and trying to figure out which side of the heart is primarily congested, left, right, or both.
And finally, T.
T is triage. This just emphasizes acting on your suspicion. Activate the shock team if you have one, or start thinking about transfer to a center with more resources if needed, making the right call early about where the patient needs to be.
That's a really helpful mnemonic. Suspect CS? What about initial labs and monitoring beyond that?
So alongside that clinical assessment, you definitely want initial labs. A comprehensive metabolic panel for kidney and liver function, an arterial blood gas for acidosis and lactate, basic electrolytes like sodium, and cardiac biomarkers for heart injury.
And lines.
A central line can be very useful early on, lets you measure CVP, central venous pressure, and SCVO2, central venous oxygen saturation. Gives clues about fluid status and oxygen delivery.
And the ECG and echo we mentioned are key early steps too.
Absolutely. A 12-lead ECG and an echo, or at least a focused cardiac ultrasound by someone skilled, are vital parts of that initial workup.
Do you need invasive hemodynamics like a Swan-Ganz catheter right away to diagnose CS?
No, the consensus is clear. You can make the initial diagnosis based on the clinical picture and non-invasive stuff. Suspect CS helps there.
But the invasive monitoring comes in later.
Often, yes. It becomes really valuable for getting a deeper understanding of the hemodynamics, the severity, which ventricle is struggling most, and dieting therapy, especially decisions about tMCS.
And once you've diagnosed CS, you need to stage it.
Yes. The guidance recommends classifying the severity using the SCAI shock stages.
Can you quickly remind us about those?
Sure. The SCAI stages go from A, meaning at risk, all the way to E, for extremis basically crashing. Stage B is beginning shock, C is classic, D is deteriorating. It gives a common language for severity and helps guide management.
And other factors matter too.
Definitely. And besides the SCAI stage, you consider the cause, AMICS, HFCS, post-surgery, etc., the setting, the timing. It all builds a more complete picture.
Okay, so you've recognized it, staged it. What about getting the patient to the right place? The guidance talks about transfers.
Yeah, this is huge. Because CS is so complex and high risk, you really need a team approach. Collaborative, standardized, interdisciplinary.
And not all hospitals have the same resources.
Exactly. You have what we might call level 1 CS centers. These places have the full spectrum, 24/7. Advanced HF docs, interventionalists, surgeons, critical care experts, all focused on shock. They have all the tMCS options, LVADs, transplant.
But they aren't everywhere.
No, they tend to be in major centers, so many patients first show up at local hospitals, maybe level 2 or 3, which have fewer resources.
So transfer is often necessary.
It often needs to be considered, yes. If the patient's needs exceed what the initial hospital can provide, guidelines suggest transfer to a level 1 center.
Is the system for this well-defined, like trauma centers?
Not yet, unfortunately. We don't have a formal, universally agreed-upon classification for CS centers like we do for trauma. It's still developing.
Which makes the decision to transfer potentially tricky.
It can be. The data on outcomes for transferred patients is a bit mixed. Some older observational studies showed maybe worse outcomes, especially for HFCS transfers.
But newer data.
Newer data from well-organized regional networks looks more promising. And the factors predicting outcomes seem to differ a bit between AMICS and HFCS transfers.
So what's the core recommendation on transfers from this document?
They strongly recommend that level 2 and 3 centers figure out their own capabilities and build a strong relationship with a regional level 1 center for consultation, for transfers.
And the level 1 centers need to be receptive.
Yes, they should be ready to consult and accept appropriate transfers. They also mention having CS champions at the referring hospitals, people who can help coordinate things.
Any specific scenarios where transfer is almost always recommended?
Yes, patients with refractory AMICS after they've already had revascularization, those patients should almost always go to a level 1 center for advanced options.
And triggers for calling the regional center early.
Things like cardiac arrest, especially with neuroconcerns, needing more than one vasoactive drug, or even just considering starting tMCS.
The bottom line being,
Don't wait. Once you suspect CS, it's never too early to call the regional level 1 center and discuss the best plan. Early communication is key.
makes perfect sense. Building on that, the guidance heavily emphasizes activating a cardiogenic shock team. Why is that so important?
The evidence really supports it. Standardized interdisciplinary shock teams are linked to better patient outcomes.
How so?
Well, single-center studies show implementing protocols and having a dedicated team lowers in-hospital mortality. And larger data sets suggest hospitals with shock teams use invasive monitoring and advanced tMCS more often and get better risk-adjusted results.
Who's typically on this dream team?
It varies a bit, but the core usually includes critical care cardiology or general critical care working closely with cardiac ICU folks, advanced heart failure transplant specialists, interventional cardiology, cardiac surgery.
What about specific technologies like ECMO?
Yeah, depending on the center, you might have ECMO specialists, perfusionists. And palliative care is increasingly recognized as a key member for goals of care discussions.
And for the level 2 or 3 centers, without a full team.
That early call to the level 1 regional center becomes even more crucial once CS is diagnosed.
What does the shock team actually do? What are their responsibilities?
They're looking at the whole picture, assessing the SCAI stage, other risk scores, figuring out if the patient needs tMCS escalation, identifying any contraindications or limitations, knowing what resources are available locally. Is the patient stable enough to transfer?
So a lot of coordination.
A ton. At level 1 centers, successful teams often have early engagement of everyone, a designated coordinating doc, a rapid activation system, smooth communication, and importantly, routine use of invasive hemodynamics to guide therapy.
Is it expected that every hospital can do all this right now?
No, the guidance acknowledges that's not realistic everywhere. Building these teams takes time. Regular case reviews, quality improvement efforts, those are vital parts of the process.
Okay, let's pivot to invasive hemodynamics again. We know it's not needed for the initial diagnosis, but what's its deeper role in management according to this statement?
Observational data strongly suggests it's really useful. It helps characterize the type of shock, assess how severe it is, and critically guide decisions about tMCS, when to start it, how to manage it, when to wean it.
But no definitive randomized trial proof yet.
Not specifically in CS, no. We can't just apply results from trials like ESCAPE, which looked at stable HF patients, but retrospective data, registry data, points towards better outcomes when pulmonary artery catheters are used in CS.
And timing matters.
Seems so. Some studies linked getting that full hemodynamic profile early within the first 12 hours to lower mortality. And there's actually an ongoing trial, PTCCS, specifically looking at early invasive monitoring in HFCS.
How does it help understand the shock better?
It gives you precise numbers. You can really figure out the congestion profile. Is it mainly left-sided failure, right-sided, or both? And we know these different profiles are linked to different outcomes in both AMICS and HFCS.
Like high filling pressures.
Exactly. High LV filling pressures, or maybe a big gap between the right atrial pressure, RAP, and the wedge pressure, PCWP, suggesting RV issues.
Are there specific numbers that are particularly worrying?
Yes. Low mean arterial pressure, high RIP, a high or outright PCWP ratio, and a low PAPI pulmonary artery pulsatility index.
PAPI. Can you explain that one?
Sure. PAPI is a calculation that reflects how well the right ventricle is pumping. It's especially helpful if the RAP is high, but the patient doesn't have severe pulmonary hypertension. A low PAPI suggests RV failure is a significant problem.
And the threshold for low varies.
Slightly, yeah. Different cutoffs have been proposed for AMICS versus, say, patients getting an LVAD. The key message from the guidance, though, is integration.
Integrating invasive data with
non-invasive imaging. Echo, POCUS. Putting the numbers together with the pictures gives you the most precise, comprehensive understanding of what's going on hemodynamically. That lets you tailor treatment much more effectively.
Very individualized. Okay, shifting gears to medications. What are the main pharmacological goals in CS?
Three main goals, really. One, mitigate congestion, get rid of excess fluid if it's there. Two, optimize cardiac output, help the heart pump better. Three, enhance perfusion, get blood flow and oxygen to the vital organs.
How do you tackle congestion?
Usually start with IV loop diuretics like furosemide. If that's not enough, you might add a thiazide diuretic or even consider renal replacement therapy dialysis or ultrafiltration to pull fluid off.
And you mentioned perfusion pressure for the kidneys.
Right, thinking about the transrenal perfusion pressure, MAP minus CVP, need enough pressure gradient to keep the kidneys working.
And for boosting output and perfusion.
That's where the IV vasoactive meds come in. It's a whole toolbox.
Let's listen to them.
You've got inotropes to increase contractility, chronotropes to affect heart rate, inopressors, which do both inotropy and vasoconstriction, inodilators, which increase contractility but also widen blood vessels, vasodilators, mainly widening vessels, and pure vasopressors, which just constrict vessels to raise BP. They can be lifesavers, but they're powerful drugs.
Yeah.
Risk of arrhythmias, increased oxygen demand on the heart. Big concerns.
So the principle is
Use the lowest effective dose for the shortest possible time needed to maintain adequate organ perfusion.
Is there one clear winner, a best first-choice drug?
You know, it's interesting. A big Cochrane analysis found there wasn't enough evidence to say any specific inotrope or vasodilator was better than others for improving mortality.
And the Duroni trial.
That compared dobutamine and milrinone directly in CS patients, found no significant difference in their main outcome.
So it's more about tailoring.
Very much so. Given how different CS patients can be, you often end up trying different agents, maybe combinations, based on that specific patient's hemodynamics and how they're responding metabolically.
Any specific considerations? Like for normotensive shock?
Yeah, if someone's perfusing poorly but their BP isn't critically low, maybe an inodilator or vasodilator makes sense, especially if they seem overly constricted. Gotta be careful with milrinone if kidney function is bad, because it hangs around longer.
And if bradycardia is the issue?
Then chronotropes might help if a slow heart rate is driving the shock.
What about pure vasopressors like phenylephrine?
Generally discouraged as a first-line monotherapy, they can cause reflex bradycardia and might actually reduce cardiac output.
So what's a reasonable starting point for someone who is hypotensive?
The guidance suggests norepinephrine is a reasonable first-choice vasopressor in most hypotensive CS patients.
And if the drugs aren't enough, especially at a level 2 or 3 center?
Then you absolutely need to consult the level 1 center and strongly consider transfer for evaluation for tMCS or other advanced therapies. Don't wait too long if they're refractory to meds.
That's the perfect segue to temporary mechanical circulatory support, tMCS. A hot topic, lots of evolution. What's the consensus here?
Right, tMCS is complex. We have to remember most randomized trials, especially in STEMI-CS, have had limitations, and we don't have many direct comparisons between different devices.
So balancing act.
Big time. You have to weigh the potential benefits supporting hemodynamics, improving perfusion against real risks, bleeding, vascular injury, stroke, infection. They're significant.
So not for everyone.
Definitely not. The guidance strongly advises against routine or prophylactic tMCS in all CS patients.
What about specific devices, the IABP, the balloon pump?
IABP SHOP2 trials showed no mortality benefit for routine IABP use in AMICS.
And ECMO.
Similarly, the ECLS-HR SHOT trial didn't find a mortality difference with routine early VA ECMO versus medical therapy in AMICS across the board.
But danger shock was positive.
It was, yes. For that specific group, STEMI-CS, mainly LV shock, using an early microaxial flow pump, showed a benefit. And an individual patient data meta-analysis also hinted at a mortality reduction with tMCS, including VA ECMO in STEMI-CS patients without hypoxic brain injury.
So the picture is selective use.
Very much so. The consensus suggests considering a microaxial flow pump in appropriately selected STEMI-CS patients, those with predominantly LV shock who are deteriorating despite meds.
And the guidance provides algorithms.
Yes, there are proposed algorithms for AMICS and HFCS using the SCAI stages to help guide therapy choices, including tMCS. But, and this is important,
Yes.
The authors stress that many therapies in those algorithms, especially for HFCS, still need much more rigorous study and proper RCTs. We don't have all the answers yet.
What are we actually trying to achieve with tMCS? What are the goals?
Mechanistically, you want to unload the failing ventricle, reduce its workload, restore systemic perfusion to the organs, and act as a bridge either to recovery or to longer-term support like an LVAD or transplant.
And maybe reduce the need for high-dose drugs.
That's another potential benefit, yeah. De-escalating pressors and inotropes.
How do you decide when to start or escalate tMCS?
Use the available data. Choose the device based on how much cardiac output support you think you need. If the current support isn't enough, if perfusion isn't improving, then escalate.
Escalation could mean
increasing the flow on the current device. Switching to a more powerful device, if it's VA ECMO, maybe addressing afterload by venting the LV. Actively managing congestion is also key.
and palliative care involvement.
Strongly recommended early on, ideally when tMCS is placed, because not everyone is a candidate for long-term options. Important conversations to have.
Timing seems critical too. Delays are bad.
Delays can definitely worsen outcomes. That first 24 hours is often make or break. Patients can change SCAI stages quickly.
Which stage is most likely to worsen?
Interestingly, patients starting in SCAI stage B, beginning shock, are actually at the highest risk of deteriorating. Need to watch them closely.
So the bottom line on tMCS is,
We need more trials, especially in HFCS, to really figure out who benefits most from which device and when.
okay, last major section, critical care management. What are the key ongoing tasks in the ICU for these patients?
It's about continuous vigilance and a structured approach, frequent reassessment, treating any reversible causes you find, managing complications from the shock itself or the therapies, supporting organ function, trying to de-escalate invasive therapies safely and early.
In communication.
Crucial, ongoing interdisciplinary talks about roles of care recovery, advanced therapies, palliative focus, and keeping the patient and family involved in those decisions is paramount.
This reassessment, it needs to be constant.
Absolutely. CS is so dynamic. You need structured, frequent checks, exam, vitals, labs, imaging, invasive hemodynamics if you have them. Maybe every few hours initially, then adjust as they stabilize. The data drives the decisions.
What about complications from the lines themselves, the big cannulas for tMCS?
Yeah, big issue. Bleeding from the access sites, limb ischemia, reduced blood flow to the leg. These need constant monitoring and preventative strategies.
How common are these?
Pretty common, especially in AMICS needing tMCS. Major bleeding isn't rare. Limb ischemia risk is definitely higher. And unfortunately, getting limb ischemia is linked to worse outcomes.
So prevention is key.
Yes, the guidance lists specific measures. But if you get uncontrollable bleeding or severe limb ischemia, you usually have to take the device out, ideally in the cath lab or OR.
And ventilation. Positive pressure ventilation interacts with the heart.
Significantly. It changes pressures in the chest, affects how much blood returns to the heart, preload, the resistance the heart pumps against, afterload, even heart compliance. These cardiopulmonary interactions are complex and need careful management in ventilated CS patients.
What about getting patients off tMCS? Weaning must be tricky.
Very tricky. And honestly, there's not a lot of high-quality evidence to guide it perfectly. It relies heavily on clinical judgment.
So what's the approach?
Daily checks. Are they stable hemodynamically? How much drug support do they still need? What's their fluid status? Is the underlying problem getting better?
And then gradual reduction.
Usually, yeah. Stepwise decrease in the device support. The pace depends on why they needed it and if their heart is recovering. Consulting advanced HF transplant specialists before weaning is often wise.
How do you know if the wean is working?
It's an integrated assessment. Clinical picture, perfusion markers like lactate, maybe echo findings, hemodynamics. You watch closely during a standard observation period after each reduction in support.
Does it differ based on the cause of shock?
Potentially, yes. Patients with acute on chronic HFCS might need a much slower, more prolonged wean off both tMCS and inotropes compared to, say, someone recovering from myocarditis.
Okay. The guidance wraps up with a framework. Recognize rescue, optimize stabilize de-escalation exit. Can you briefly walk us through that?
Sure. It's a nice conceptual model. Recognize rescue is about spotting CS early and intervening immediately to restore perfusion.
Got it.
Optimize is tailoring support meds, maybe tMCS, to get them hemodynamically stable, often aiming for a MAP around 60-65.
And stabilize.
Stabilize is focusing on organ recovery, managing other medical problems.
And finally, de-escalation exit.
That's assessing if the heart has recovered. If yes, weaning support. If no, figuring out the long-term plan, durable MCS, transplant, or maybe palliative care. It covers the whole journey.
What are the absolute must-know takeaways from this 2025 ACC statement?
I'd say 1. Cardiogenic shock is complex, dangerous, high mortality. 2. Early recognition using tools like suspect CS is critical. 3. Standardized shock teams and regional systems of care improve outcomes. Consider transfer early.
Okay.
4. Invasive hemodynamics are really valuable for guiding therapy. 5. Serial reassessment, especially in the first 24 hours, is essential to track progress and prevent organ damage. 6. That coordinated team-based approach is key for navigating both short-term and long-term strategies.
Excellent summary. Some really crucial insights there. It leads to a final thought for everyone listening. Given how complex and high-stakes CS is, how can your own institution best put these recommendations into practice?
Yeah, how can you optimize care and outcomes with your local resources? How can you strengthen team collaboration? How do you keep learning in this field?
Definitely food for thought. Thank you so much for walking us through this incredibly important guidance.